share my screen. Let's see. Okay, can you see my screen? Perfect, perfect. So this is a very interesting topic to me. It was interesting. Yesterday, I was telling a friend that I was going to talk about eating disorders during pregnancy and postpartum. And my friend told me, everyone has disorder or problems with eating, you know? And I started thinking about that. And it's so common, not to have an eating disorder per se, but to have issues with food or eating, and that they can clearly exacerbate in pregnancy and postpartum. So we'll talk about that. Okay, so the most common eating disorders in the reproductive years are anorexia, bulimia, and binge eating disorder. And we'll talk about each one separate. They can decrease the quality of life and increase mortality rates. And we know that anorexia is associated with suicide and also with medical complications, and the mortality rate is 5%, which anorexia has the highest mortality rates for all psychiatric disorders. So it's important to keep that in mind. And they have a lot of comorbidities, medical and psychiatric, and very common to have anxiety disorders, depressive disorders, and less so substance abuse, but also very common. And the prevalence in the last lifetime is 0.4% for anorexia for women, 1.5 to 3% for bulimia for women, and binge eating disorder is 3%. And both anorexia and bulimia are much more common in women. Binge eating disorder has less of a difference between women and men. So anorexia, usually 20% have a chronic course, with some people, 33% have a partial improvement, and 46% have a full recovery. And bulimia, there is a short-term recovery rate that seems better, 50 to 70%, but there is a high relapse rate, with 30% relapsing at 6 months and 85% relapsing at 6 years post-treatment. Binge eating disorder, I didn't have the prevalence, but it's common, and it's associated with obesity. So the importance of pregnancy and postpartum is because it's a time of high risk of having a relapse of any eating disorder behaviors, but it's also a time that some women feel more motivated to make changes. So that's really good. And the remission rates during pregnancy are 29 to 78%. But some women have a very hard time with the changes in their body, how it looks, and other things like the food cravings, the morning sickness can trigger an eating disorder. Some women have hyperemesis gravidarum, and it's associated with worsening of the eating disorder during the peripartum period. And the stressors that happen in the postpartum, taking care of a new baby, not sleeping, seeing your body, how it changed. Some women have the magical idea that as they give birth and they should be back to their pre-pregnancy body. And all that can be very stressful. And there's less of a motivation to change your behavior because of a baby, because you already gave birth. So in some instances, there is increase in eating disorders at that time in the postpartum. So I wanted just to mention pica. Pica is a rare eating disorder, but it's the most common eating disorder during pregnancy, with a prevalence in pregnancy of 27%. And what is pica? Is the craving and chewing of substances that have no nutritional value. So like ice, clay, soy, or paper. It's common, it happens. I used to do OBGYN and I used to see it. And I wonder if people here that do OBGYN, if they see it. And we can talk about it later. There is thoughts that because there is iron deficiency in pregnancy and the stress of pregnancy might increase the risk of pica. And the rates are higher in Africa and those with low educational levels and socioeconomic status. So what are risk factors for eating disorders? So there are biological, environmental, psychological, sociocultural. So there is a strong genetic basis, family history, hormonal changes can trigger, can be a basis for eating disorder, and type 1 diabetes. In terms of environmental, any time that more in children, when there is a lot of criticism from their parents, family dieting, family discord, any way, like in some families, the way they deal with food is very rigid. It's very much, you have to diet, you have to be thin. That can be transmitted in terms of their thinking to their children, and also history of abuse. Then body image dissatisfaction, perfectionism, impulsivity, cognitive inflexibility. And what was very interesting is to think about the sociocultural factors, like media exposure to the thin ideal, weight stigma, and the endorsements of dieting in the society, like all that can have a big impact. More eating disorders is usually seen a lot in young women, in adolescents at the beginning. So that's a time that women are and adolescents are really paying attention to social media and what's going on with their peers and to be accepted, So other risk factors for complications also of the eating disorders during pregnancy and postpartum. So lack of weight gain in second trimester, and we'll talk more about that. It's important to keep an eye on the weight of the patient, and mostly in the second trimester. So one thing they say is to check, to be in the lookup for if they don't gain weight between 2 appointments, so because there is a lot of secrecy and a lot of women will not tell you they have an eating disorder and they are suffering from it, or what are they thinking and how they are eating. So you have to be on the lookout for it, so not gaining weight in second trimester between 2 appointments is one red flag. Then hyperkalemia is a risk factor, electrolyte abnormalities, as I said, hyperemesis, low body mass index, GI problems, sexual dysfunction, low bone density, miscarriage, so fertility, and we'll talk more about this, preterm delivery and low birth weight of the offspring. So you have to have a low threshold to screen, and a lot of it because there is a lot of denial and secrecy surrounding it. I was thinking about that. I saw a patient for preconception a few days ago, and she kept repeating to me, like I wanted to give her a medication, an antidepressant, and she kept repeating to me, but are you sure it's not causing weight gain? Are you sure it's not causing weight gain? And I explained to her the data about the medication, but she kept kind of telling me at the same time, but I'm okay the way I am, like I don't have an eating disorder. It's just that I'm very, very concerned about gaining weight, but it was a little bit too much the way she was repeating it. So in the back of my mind, I was thinking I should screen her for an eating disorder and ask more questions about that. So there are several screening tools that you can find and can be used. I didn't find anyone validated particularly for pregnancy and postpartum, but these tools that I mentioned here are validated for primary care and specialty care settings, it says. So I assume they can also be used for OBGYN. The eating disorder screen for primary care, it's a 5-question questionnaire. The SCOF is also a 5-question questionnaire. The eating disorder examination questionnaire is a 28-question test. And so it's a little bit longer, but all of them are fine, and you can find others that can be helpful. And if you need me to send you these ones, I'll send you, let me know. And they suggest to screen women usually during times of transition. So during puberty, young adulthood, peripartum transition, so pregnancy, postpartum, and during the perimenopausal period. There are some studies that suggest that there is an upsurge of bulimia nerviosa and binge eating disorder during the perimenopausal period, and also a little bit from anorexia. So what are the main features of anorexia nerviosa? So there is an intense fear of gaining weight, and there is low body weight. The woman doesn't see her body as it is in terms of weight, so she might be skinny and she will tell you, no, look at me, I have a lot of fat, I'm overweight. So that's part of the diagnosis. And there is a restriction of energy intake in terms of food, liquids, So in terms of physical symptoms, and it depends on the severity of the disease, but the woman can have bradycardia, brittle nails, dehydration, edema, electrolyte imbalances, hypotension, hypothermia. Lanugo is the little hair that the babies have. So they can have starting like facial hair that it's very thin, and it's called lanugo. Osteoporosis, renal and liver damage, and amenorrhea. It used to be amenorrhea one of the criteria for anorexia. Now it's not anymore as the DSM, but it's still important to ask. And then it can be associated with anxiety, depression, denial, and high risk of suicide. So in terms of perinatal complications, there is a high risk of C-section, infertility, low gestational weight gain, so they don't gain much weight, perinatal depression, preterm labor, substance abuse, and unplanned pregnancy. So very important to keep an eye. These women can get really sick physically, and that can affect the baby. You have to make sure they are gaining the weight they need to gain, and they are keeping their nutrition up to date, like in a good way. So they need a lot of close monitoring. Bulimia, the features of bulimia is binge eating. The DSM says that at least one episode per week in a lapse of 3 months. And the woman is usually body weight is normal or overweight, and she has purging behavior. So she might use laxatives, diuretics, she might induce vomiting, she might overexercise. And then as a physical symptoms, you can see physical symptoms also associated to the induced vomiting, like dental caries. The Russell sign is when they have scars in their fingers because of inducing their vomit. They can have edema, also electrolyte imbalances. They can have esophageal tears because of inducing vomit, gastric problems, hypotension, menstrual irregularities too, and very much associated with polycystic ovarian syndrome. And both bulimia nerviosa and binge eating disorder are more associated with impulse control disorders and anxiety and depression. So in bulimia, usually there is excessive gestational weight gain. There is high risk of C-section, infertility because of the hormonal changes that happen during the eating disorders, and we can talk more about that. Preterm labor and unplanned pregnancy. What happens is that because of the lack of electrolytes, nutrients, and vitamins, there is changes in hormones like low leptin, increased ghrelin. There are changes in insulin and peptide YY, that they are both associated with reproduction. And there is changes in the way the hormones, the sexual hormones in the hypothalamus is released, and that brings down the hormones, the sex hormones in the hypophysis and estradiol. And that creates that the follicles are small and the ovaries are small. So there are sometimes no dominant follicles, and that creates difficulty getting pregnant. So, and the menstrual irregularities. Binge eating disorder, it's associated with binge eating. The women might be overweight or obese, but there's no purging. It's just the episodes of binge eating. And it can be associated with medical complications that have to do with obesity, like diabetes, heart disease, hypertension, obstructive sleep apnea, irregular periods, and also very commonly associated with polycystic ovarian syndrome. And as I said, with bulimia, it's also associated with anxiety, depression, and impulse control disorders. In binge eating disorder, they can also gain excessive weight. They are more at risk of gestational diabetes, of having babies that are large for their age, gestational age, hypertension, also perinatal depression, and prolonged labor. So eating disorders in general are also associated with other things, like what I was saying before, like nutritional deficiencies. So anemia, electrolyte imbalances, vitamin deficiencies. Usually women with eating disorders breastfeed for less time, and they have poor bonding. That can be also related because many of these women have postpartum depression, and that can create a poor bonding. They can have preeclampsia, and as I said before, substance use disorders. In the infant, what you can see of women that had an active eating disorder during pregnancy, they can have developmental delays that, at least on the studies done, the babies didn't catch up to their peers, you know? So they can have intrauterine growth restriction, low birth weight, or they can be small or large for their gestational age. There can be perinatal death, premature birth. And with bulimia, there is something called slimming, that it is that the woman kind of identifies with the baby and sees the baby as fat and restricts the feedings of the baby or induce vomiting in the baby. So important to keep an eye and be aware of that. In terms of treatments, the most important thing to remember is that the treatment should be multidisciplinary. So you have to make sure during pregnancy in particular to make sure that they are eating healthy, that they are getting all their nutritional things that they need, that they have the weight they need to have. Psychotherapy is very helpful, and medication is a little bit less than psychotherapy. And so in pregnancy, you really need to focus on weight restoration and adequate nutrition. So very early, do an early referral to nutritionists and get vitamin supplementations. And as I said, monitor the weight closely. So one red flag is if they don't gain weight between 2 appointments in the second trimester. So just monitor their weight every pregnancy. When I used to do OB, I had a patient with bulimia, and she didn't want to see how much she weighed. So to weigh her, we had to cover the scale so she couldn't see the weight. And then we knew how much she was gaining weight. And then it's very important to educate the woman about the risk of the illness for her and for the pregnancy. And a lot of women, because it's a time that motivates women, they might be able to make the changes that they need. The other thing is to educate them also if they are preconception and they can't get pregnant. So help them understand how their eating disorder is affecting their ability to get pregnant. In terms of medications, so SSRIs, the antidepressants, are the most prescribed medication. They are not so helpful for anorexia. They are more helpful for bulimia and binge eating disorder. They seem to help with the binge purge episodes. And fluoxetine has been approved by the FDA for bulimia. And there are some studies that show that higher doses are better than lower doses. They are more effective. And it's always very helpful, the antidepressants, to treat the comorbid anxiety and depression. And you can use the other SSRIs, not just that you can use just fluoxetine. The other ones are also helpful. The important thing to remember is that it's very important to avoid bupropion when somebody has an eating disorder, because bupropion can decrease appetite, so that's not helpful if a woman, let's say, has anorexia. But also bupropion increases the risk of seizures, and women that are actively having an eating disorder can have increased risk of seizures because of the electrolyte imbalances that they have. So it's important to keep that in mind. We have the old antidepressants like the tricyclics that are more, they can be used, but they have more side effects like constipation or GI symptoms that usually women with anorexia can have them already, and that can be very upsetting. So we try to use the SSRIs. Antipsychotics have been used more for anorexia. And the one that has most evidence is olanzapine, seems to help with the weight gain, but the results are really mixed. It doesn't seem great evidence to use antipsychotics unless you are treating, really you want her to gain weight. But for the symptoms, for the thinking, the rigid thinking that a woman can have with anorexia, antipsychotics don't seem to be so helpful. Then in terms of medications that you use for weight loss, there are a lot out of there, but topiramate is one that we also use in psychiatry, and it decreases the cravings for food, but it's associated with malformations, with hypospadias and cleft lip and palate, so we tend not to use it. Then, as I said, the most important part of the treatment is weight restoration and nutritional rehabilitation. So women need to be monitored very closely, that in terms of their feedings, like that they are eating regular and structured meals. It's important that somebody watches them when they are eating to make sure they have an appropriate intake and that they are not engaging in any compensatory mechanism like self-inducing vomit or over-exercising or using laxatives. It's very important to be careful when you start refeeding them. There is something called refeeding syndrome that can create electrolyte abnormalities, and it can be very dangerous if you kind of feed them very aggressively at the beginning. So you have to monitor closely for their phosphorus, magnesium, potassium, and supplement with vitamins, thiamine, vitamin B complex. So you have to, somebody needs to be making sure, more when they are inpatient for refeeding, that they do it slowly. There are a few studies that suggest that you can be a little bit more aggressive, but women need to be really observed and how their electrolytes are while they are being starting to feed again. In terms of behavioral interventions, first you need to establish what level of care the woman needs. You know, is she at risk of having severe medical complications? Is she at risk of suicide? You need to find what is the place she needs to be in: inpatient, partial hospitalization, outpatient intensive, or a regular outpatient program. It's very important to have a multidisciplinary team that includes the psychologist, the psychiatrist, the medical provider, the doctor, the dietitian. So you really want to have everyone on board to help the woman. And CBT has the best evidence for bulimia nervosa and for binge eating disorder. There is a little bit, interpersonal psychotherapy also has some evidence. And then dialectical behavioral therapy seems to help for women with impulse control disorders, that are associated with the eating disorders. But CBT is the one that has the most evidence. So in people that are younger, they might benefit from family therapy, including the parents, if it's a young woman that still lives at home with her parents, because the parents need to make sure she eats, they need to be on board. Also, there are family dynamics that might be exacerbating the eating disorder. Sorry, it's very important to have the family involved. So family therapy might be a good idea. Okay, so any thoughts or questions about eating disorders?
I have a question.
Yeah.
You had said with both bulimia and binge eating disorder, there's higher rates of PCOS.
Yes.
What's the connection there?
So, I was thinking about that. And what I'm thinking is that PCOS, they have a increased resistance to insulin, I think it comes from that side. And when you are restricting or overeating, or like your insulin levels, like in people that are obese, they have resistance to insulin, So I'm thinking it comes from the insulin part, like that there might be an association.
Cool. Can I ask another question about your thoughts on recent, like Ozempic?
Yes.
Coming with some of these patients, especially with like some binge eating stuff. Like I've got a couple people doing it now, and I don't know. What do you think?
So I also have some patients on it. I think it's helpful in terms of decreasing the cravings for food. And what it really does is that decreases the insulin resistance, so people are more able to lose weight or to maintain in a way without having these episodes of cravings. You can't use it in pregnancy. So
do you think it contributes to like eating disordered patterns, especially around like the thought process around food and restriction, especially like once they stop taking it?
It might, I think the problem is that it's like, I think that's a treatment for long term. When you stop it, it can come back, everything, the insulin resistance, the cravings, so it can be a real problem. So I think the important thing I think now people are getting it very easily, like everyone is on Ozempic now or on those medications. But I think it needs to be thought better, in terms of like what happens with that woman when she doesn't have access to it or for some reason, because yes, it can reverse back to previous behaviors.
Thank you.
So Chelsea, there are 3 questionnaires. The 2 that have 5 questions, one is called Eating Disorder Screen for Primary Care. The other one, it's called SCOFF, that is SCOFF. And what it is, the S is, do you make yourself sick because you feel uncomfortably full? The C is, do you worry you have lost control over how much you eat? The O is, have you recently lost more than, they call it here 1 stone, that is 6 kilograms in a 3-month period. The F is, do you believe yourself to be fat when others say you are too thin? And the other is would you say food dominates your life? So you have to answer yes to 2 or more questions. And that is a screening. So that means that you need to refer them for an appropriate evaluation after that, for a diagnostic evaluation. I was interested for the people that work in OB. Have you seen pica when they eat clay or soil or ice or paper, like things that are not nutritional?
Yeah, it's interesting you say the ice thing, because that's all I ate during pregnancy was ice. I craved it all the time. And so I didn't even think of it being connected to that. I was, I had heard like maybe an association with an iron deficiency, and I was anemic during pregnancy too. But I ate pregnant, that's all I wanted was ice.
Yeah. Yeah, it's common.
Mm-hmm.
And how do you see a lot of eating disorders?
I don't think we're asking enough questions about it.
Yeah.
When I started talking to a lot of people more, instead of like eating disorder, like eating disordered behaviors, because especially with so many, like it seems like young women and women in the postpartum period, there are so many like negative thoughts around body and food, and especially just with social media and the emphasis on like healthy food and clean eating. And so I talked to a lot of people just about like more of an intuitive eating approach and not necessarily labeling food as good or bad. And so I don't know, for a lot of my people, I don't know if they really meet full criteria for an eating disorder. There's definitely a lot of disordered eating behaviors happening that we work through.
Yeah. Yeah, I think we see a lot of, it's easier to see the behaviors that are abnormal, like women are very secret about having an eating disorder. It happens to me a lot with my patients that are fertility patients, that usually the reproductive endocrinologist asks them about eating disorders, and usually they want a letter from me saying that they don't have an eating disorder. So women get very concerned about that, and they might not say, or they might say it was very many years ago, I'm totally fine, They might minimize because they are concerned that you will not support their process of fertility.
Mm-hmm.
Would you ever recommend universally screening for eating disorders in like new OB paperwork? Or, patients fill out a ton of paperwork when they come into clinics, but would that be something that would be recommended, is to take one of those screeners and universally screen all of our patients?
I would. I think it will be, it's like a short screen, like it doesn't take so long, and the thing is like, because sometimes what I see in OB clinics, the pace is so fast, you might not have time to ask those questions, and to see the red flags. So I think with that, they can also answer no to everything, like that can also happen, but at least you are trying to elicit.
Can you guys hear us?
Yes.
Oh, okay. All right. I wasn't sure if the microphone in here was working to pick us up. I just had an interesting experience. I'm a home visiting nurse, and a lot of what we do is lactation. And I had a client recently tell me that, she had disordered eating in her past and has gotten treatment, but she's had low milk supply. And so there's been a lot of discussion over, how to feed the baby. And she texted me the other day saying that her daughter was going to get her first bottle of formula. And I asked her how she was feeling about that. And I just thought I'd read about what she said. Just channeling everything we've learned in eating disorder treatment, all foods fit. Foods don't have moral value. Rose body knows exactly what to do with formula. And I think it's common for us to encounter women that have really big biases against formula or alternative ways of feeding their baby. And I just wonder if some people with more, potentially, if there could be a link between more disordered eating and feeling as though there's a real moral value on things like formula that may actually be essential to a baby growing properly if mom's not, like how many moms would resist doing that because they just don't feel like that's good enough, and how that relates to how they feel about food and what you put in your body and things like that. It's just an interesting connection.
I think that's a great comment. I think really the way women think about food translate a lot into how they deal with their children, and so it starts with breastfeeding and with formula feeding, and then it goes up until the kids are grown, so that's the beginning, and I totally see that, I can see that happening.
Yeah, really attaching a lot of moral value to food. It just, like, maybe if somebody is really struggling with that, that might be a good gateway to maybe doing a screening for them, or bringing up their relationship with food. I mean, of course, there are a lot of other things that go into people's perception of formula and breastfeeding and all of that stuff, but bottom line, we just need to feed babies.
Yeah.
And so anyway, I just, for those of you that are counselors, if somebody is really struggling with how they're feeding their infant, I think it might be an interesting thing to ask, So.
Yeah, thank you. Any other thoughts? The other thing is the high association with depression and postpartum depression, and the effect that has in the bonding with the baby, and so that's very important to remember, The other thing is that with the menstrual irregularities and the unplanned pregnancies, many women might not know they are pregnant until certain time into the pregnancy, and they might be using laxatives you can't use or diuretics you're not supposed to use, and then realize they're pregnant later on into the pregnancy. So that's important to keep in mind. But I always ask my patients about their image of themselves, how they see themselves, how they see their body. And it's hard when you do telehealth, because you don't see them like the whole body, so you don't know really what they look like, but you can have an idea. And I always ask how much they weigh, how tall they are, and to try to figure out if it's accurate what they are saying, if their body image is healthy or not. But that can be the first part to talk about an eating disorder. Like, I think the amount of patients I see with a history of eating disorder in adolescence, it's astronomical. Like, it feels that everyone has a history of eating disorder. It might not be, it might be that it was diagnosed very loosely, when they were an adolescent, and it might be just an eating disorder behavior, but still, like, a lot of people tell me they had eating disorders when they were adolescents. So that should be also a red flag for later on. And when you are dealing with them in the peripartum period, it's a time of increased stress and increased risk of having a relapse. Any thoughts, any cases you want to bring? Any? No.
What are your thoughts on, I have a client right now, she's actually not a perinatal client, but she's a young woman with some pretty significant eating disorder behaviors happening. And she won't get further treatment. I'm not an eating disorder specialist. I've asked her multiple times to connect with several different people that I've given her, and a nutritionist and her medical doctor. And I called her medical doctor and I called her psychiatrist, and felt like nothing's happening. She's not doing anything. And so I'm having a hard time navigating this with her because she won't get further treatment.
Because she's scared, I'm sure, to gain weight, and to lose control. There is an issue of control there, and it's really hard to lose that control.
Right.
So I wonder, if there is, I don't know her, but if there is any way of something that's really important for her, that can be affected by her eating disorder.
Yeah. Well, unfortunately, mom has a pretty good history, and mom reinforces it for her, making comments. What did she say? They just went to Vegas, and her mom made a comment about how much weight she'd lost, and she said, well, if you keep it up, you're going to be looking good for Vegas. And so those are the messages that she's receiving and within her family system. And I mean, it's hard to break all that down.
Totally. And that's a really good point. I see that a lot. The family history, not just genetics, but what is the message they are receiving at home, and they were receiving as children, like that. I see a lot with people with eating disorder, that the mother was very thin or was very concerned about food and was restricting food, and
well, even just some of the social messages we receive, everyone has a comment about somebody's body. And so if you oh, you look great, you've lost all this weight, and not necessarily knowing that maybe they did in a really unhealthy way, or they didn't have weight to lose in the first place. And so then it's reinforced by these accolades that they get for being thin, and obviously everything that people see on social media. And it's really multi kind of factored.
That's true. Scary.
Mm-hmm.
Do you see a connection with women who have type 1 diabetes and having lots of trouble with eating disorder behavior? And
I think that's a great point. And also when they have gestational diabetes and they use insulin, they see how they can lose more weight, or if they start using insulin, they might not lose the weight they want to lose, and so that's a big problem.
I have a patient, she delivered, but she's got type 1 diabetes that's been difficult. I mean, she wouldn't really let doctors touch controlling it or anything, but she's very thin and her albumin's also really low, and she's experiencing a lot of dizziness now, I'm sure from dehydration and losing glucose and stuff, the urination. But I've been urging the doctor that she needs a consult for therapy, she's been preached to multiple times about controlling her diabetes. She doesn't want to hear that anymore. That's not getting us anywhere. She won't bring in her numbers. She won't tell us what she's eating. That's not working. But maybe you'll get a referral.
Okay. That's it is a big problem with diabetes. Like I used to work in a medical clinic as the psychiatrist, and I saw it a lot, like eating disorder behaviors associated to diabetes type 1. Any other thoughts?
We were just saying that it feels like such a hot button issue that in bringing food and weight management up in general feels like very triggering and hot button and hard to do well without it being pathologized. It just seems like a very hard topic to engage with.
Yeah, that's true. Yeah. It is, and we hear all these stories about people, with eating disorders, young adolescents, and my daughter is 11 now, and she the other day came and she told me, how many calories an avocado toast has? And I almost lost it. I was like, what's wrong? Like, I almost lost it. I was so scared. And then she was like, oh, we had health today and we learned about calories. So she was coming from a totally different place, but there is so much going on with food and media and eating disorders that I was like, no, I wasn't very therapeutic or very helpful. Good. So we are thinking, so I will ask you because we are thinking, so this year we have one more time that will be on June 28, and we will talk about complex cases. So I will ask you if you have any cases that you want to discuss, bring them that day and we can talk about them. I will bring some cases in case you don't bring, but that will be the focus. But we want to start thinking about next year, starting in September. So if you have any topics that you think are important that we cover, if you can email us and let us know what topics you are thinking, because either if it's something that we need to redo again or, go more in depth or anything, we can talk about so many things. So let us know if you are thinking, because we want to start and have the schedule for next year.
And you said June 28th is our next one?
Yes. Yeah, because I think June 14 is the Metalwork conference. So we will be there.
If we have a case that we'd like to present, do we need to give you any information beforehand or just kind of bring information?
Yeah, just bring it.
Okay. Yeah, we have one that's pretty complex, and I'll ask our counselor if she wants to present on her, because we could definitely use some guidance.
That's
She has a lot of stuff going on.
That's great.
Awesome. Thank you.
Sure. Okay, perfect. So just be in touch and if you need, and we will meet on June 28th.
Thank you.
Okay.
Thank you. I'll call you later.
Okay, bye.
Bye.